Why don't we wait a second and then we'll get going? Everybody have a nice weekend? Hope so.
Yeah. Yes. Yeah, wasn't a bad weekend at the hospital either.
That's right, Grace. You and I have been communicating all weekend.
Always.
Best part of my day. Okay. So I see. All right. I think really we're only missing David, and he's probably out for the Passover holiday. So why don't we just get going? This isn't a very long conference today, so I apologize for its slight brevity. Okay. I was reading ZO patches, or actually I was reading a monitor from another physician that's been referred to me. And this is the tracing. And the question is whether or not you agree with the assessment of third degree AV block. So why don't I ask Dr. Lawalia what she thinks?
Let's see. So I'm trying to watch the P's and QRSs. The first PR looks okay. Second is significantly prolonged. And the third P does not conduct, but the P is quite early next to the T in that. But then
of this beat here.
Right. And then again, that seems to be conducted, and then the P is very, PR is super prolonged. I mean, this, and the RR is very fixed. So I would say on this rhythm strip, on this amount of beats that I'm seeing, I'm not 100% sure, but I think I would call it heart block.
Third degree, you mean?
Yeah.
I agree.
Yeah.
So the first thing you want to do when you see a tracing like this, as you rightly said, is to look at the R to R interval. And remember that when somebody has complete heart block, usually the R to R interval has very little variability on a single strip. Yes, over a 24-hour period, under different adrenergic stresses or scenarios, patients will have different degrees of ventricular rate. However, in a period of 8 to 10 seconds that you're looking at a strip, the R to R interval ought to be fairly close to each other. And you can see even by these measurements that the computer is automatically making that we're talking about 10 millisecond or even smaller, 10 thousandths of a millisecond difference between the R interval. So this R to R interval is quite fixed, and you're correct. A P wave like this might not conduct normally, even in a person with a normal heart rate, a normal AV node rather, because the QRS to P wave interval is so short, almost a rate of like 250, then maybe the AV node would be refractory. But a P wave like this ought to conduct, and probably a P wave like this ought to conduct. And so if this P wave is certainly far enough after the last QRS, this is a rate of like 100 or less, or more rather. And so this QRS should be brought in if there were any conduction at all. So this is third degree heart block. And this is the patient's, so I should give you a little bit more history on this patient. This patient has a structurally normal heart and was identified at 14 in complete heart block. And this is the these are the numbers from the 24-hour Holter. And this says first degree AV block, but this is obviously erroneous. So Neha, if you have a 16-year-old who comes into your office and you are assessing them for the first time, and you've been told that the referring doctor said there was heart block at 14, I guess my first question would be, what would you do to evaluate this patient? And then my second question would be whether or not you believe this patient deserves a pacemaker. Is there anything you want to know in order to help make this type of decision? This is kind of an important one.
Right. Did he present with any symptoms, or does he have any symptoms?
That's a very good question. In this case, the patient does describe being a little bit tired with exertion, but really no specific symptoms. In other words, there's been no syncope or anything of that nature. No.
Okay. And I would do an echo to make sure. You said it's structurally normal, but I would like to rule out any heart disease or any myocarditis, cardiomyopathy.
Okay. So what would you expect? And let's say that there is no evidence for that. Would you find anything abnormal in somebody in complete heart block at this age? What would you find? What would be a normal finding in somebody who has this type of heart block?
I think they can have atrial dilations with
Not usually. Usually ventricular dilation, right? Because there's really only two ways for a patient in heart block to increase their cardiac output, right? That's to increase their stroke volume or their heart rate. And since they have a limited ability to increase their heart rate, in this case, this particular patient can only increase their heart rate to 92 beats per minute. The only alternative is to increase the stroke volume. But as you know, the human heart can only dilate so much, but you would normally see dilation in someone who has chronic complete heart block. And you would normally see, most of the time, the function would be normal. And you might even see some mild stenosis of the semilunar valves because of the enhanced volume. But it's usually at a very low level, not a level that would be concerning. So let's say that you do your echo, and that is what you find. You find that the patient has normal systolic ventricular function. V-score in the ventricle of, let's say, 2.5 volume. And but the systolic function is normal, and it is structurally normal, and there are no holes or any other congenital anomalies. So how are you going to decide whether or not this patient ought to have a pacemaker or not? Because that's why you're being referred this patient.
Right. Other things that I would do, low yield, but still would want to rule out, is like thyroid and Lyme.
Right. Absolutely. You always want to do a thyroid screen and Lyme disease. I'll tell you an interesting story. I used to have a patient with hypoplastic left heart syndrome who had chronic congenital hypothyroidism. And when that patient was a teenager and the mother had started allowing the patient to take their medicine alone, she came into the office, this is a number of years ago, in second degree AV block, hypoplast. And I was very concerned about it. And we grilled the patient in the office whether they were taking their medicine. She assured us that she was. And then about an hour and a half later, I got a phone call from the car of that patient that the mother told me that she admitted in the car that she had not been taking her Synthroid. And in fact, when she started taking her Synthroid, her conduction recurred. But that's one of the rare times in my entire career of 23 years as an attending where I've actually seen that. But it is possible. So you should do that. Should also do studies for inflammation, right? It could be an acute event, very, very unlikely since the patient isn't showing any other viral symptoms, but you might want to do either an ESR or a CRP or something along those lines. But let's assume, so that's good. Let's assume those are all negative. So basically you have an otherwise healthy person who's complaining of being tired. It's a 16-year-old, so I'm sure you already have surmised from your work as a general pediatrician and as a cardiology fellow that it is the rare 16-year-old who is not tired. Um, how are you going to decide if this patient needs a pacemaker? Are there criteria, for example?
There are criteria and guidelines that can help us. And I'll have to look, but if I remember correctly,
Why don't we go through those then?
yeah, it's like minimum heart rate that you 40 without heart
So,
disease.
as in all things, there are ACC, AHA recommendations, or not all things, but in many things.
Mm-hmm.
These are the recommendations for permanent pacing in children, adolescents, and patients with congenital heart disease. There is no real one for just children, so we sort of use these. So the class 1 indications would be advanced second or third degree AV block associated with symptomatic bradycardia, ventricular dysfunction, or low cardiac output. So you could, on the basis of the symptom, recommend pacemaker because the patient is complaining of being tired. And in fact, when I spoke with this patient at length, what he told me was that there was a distinct change in his ability to exercise and to do things. In fact, he specifically said that he felt as if he hit a wall very early when he was doing any kind of sports activities. So, although it is certainly true that most teenagers are complaining of tiredness, this is a boy who previously was apparently quite energetic and did a lot of sports. So so in this case, I felt that reached a class 1 indication. But let's just, for completeness sake, review all of them. Class 2 is a sinus node dysfunction with correlation of symptoms during age inappropriate bradycardia. Third class 1 indication is postoperative advanced second or third degree block that does not resolve by 7 days after surgery. And we've discussed in the past why we pace all of those patients, even when they appear to be clinically well. Congenital third degree AV block with a wide QRS escape rhythm, complex ventricular ectopy, or ventricular dysfunction. Congenital third degree AV block in the infant with a ventricular rate less than 50 to 55, or with congenital heart disease, a ventricular rate less than 70. Okay. Which is pretty much why almost every infant who has congenital heart disease of any significance beyond very simple disease gets a pacemaker. And then sustained pause-dependent ventricular tachycardia with or without a long QT, in which the efficacy of pacing is thoroughly documented. Okay. I might add one other thing you might want to do in the workup of a patient like this is to ask the mother if she has lupus. And in this case, the patient's mother told me that she did not have lupus, but I explained to her that oftentimes the first presentation of lupus is a mother whose child has heart block. And that diagnosis is made not uncommonly in this scenario. And I recommended that she mention this to her internist and that testing, for lupus anticoagulant or things of this nature be performed at her next well visit. Now, the class 2A indications are bradycardia, tachycardia syndrome with the need for long-term antiarrhythmic agent other than DIG. So that would be sort of your Fontan type patient or your Mustard patient. Congenital third degree block beyond the first year of life with an average heart rate less than 50. Abrupt pauses in the ventricular rate that are 2 or 3 times the basic cycle length or associated with symptoms due to chronotropic incompetence. So that heart rate of 50 is important because when the Holter shows an average heart rate less than 50, this is essentially saying that most of the time it would be correct, probably, in the opinion of most electrophysiologists and cardiologists, to put a pacemaker in. Now, I've had a lot of patients, and I've seen many of my colleagues have a lot of patients who are sitting in the 40s and are feeling fine and doing well. But 50 is pretty much the line in the sand where we at least start really thinking about a pacemaker. And you'll remember that in this particular case, the average heart rate was exactly 50. Long QT syndrome with 2-to-1 AV block or third degree AV block, asymptomatic sinus bradycardia in the child with complex congenital heart disease with a resting heart rate less than 40, or pauses in the ventricular rate of more than 3 seconds, and then patients with congenital heart disease and impaired hemodynamics due to sinus bradycardia or loss of AV synchrony. And remember, a class 2A indication is essentially one where most authorities believe it's the right thing to do and appropriate, but it is not an absolute requirement to do. So I think on the basis of the average heart rate being just at 50, but the more important thing being that the patient is complaining of chronotropic incompetence in terms of exercise, I recommended that the patient undergo pacemaker insertion. And at this age, we could certainly place a transvenous pacemaker. And Neha, what is the, how do we determine whether a patient can get a single or a dual chamber pacemaker in terms of size and weight? Are there characteristics or sizes that we use as general rules of thumb?
For dual chamber pacemaker, transvenous system, I think 15 kilograms.
No, that's actually what we would say usually for a single chamber device.
Okay, single chamber for 15 kilos.
Remember, one of the things that I remember early in my career thinking was surprising was how big pacemaker leads are. You know that the average transvenous pacemaker lead is 7 French. So think about when we do cats, right? You're going to be an interventional cardiologist. You don't put 7 French sheaths in babies, right? Unless we really, really have to. And so a 7 that's a big honker to put into somebody. Now, there is this special lead comes from Medtronic. It's been around for about 15 years called the Select Secure lead, which is 4 French, which is really a nice lead. It's put in a somewhat unusual manner compared to usual leads, but it's a transvenous screw-in electrode. But most standard pacemaker leads are actually 6 or 7 French, and defibrillator leads are usually 9 French. But okay, so we decided 15 kilos for a single chamber. Any knowledge about dual chamber?
I don't remember, 30 kilos.
Usually about 25 to 35 kilos. Yeah. So, and this is made up, but these I would say these are the general parameters that most electrophysiologists would use to make this decision. So a 16-year-old, assuming they're otherwise healthy, should be over 30 kilos, 25 kilos. So this would be a good candidate for a transvenous dual chamber device. Okay, good job. All right, let's move on. So this is an event recorder that was obtained a long time ago. I want to thank pdcardiology.net for the next couple of tracings. For those of you who are interested, this is a fellow or a former fellow from Texas Children's who has a lot of very interesting tracings in all areas of cardiology. And I've followed his website for a long time. So why don't we ask Sergey what he thinks is going on here?
Good morning.
Hi, Sergey.
So these are just the channels from the kind of a recorder, right? So it's not like an atrial or specifically ventricular channels, no? These are just
correct, and that's an important question. You know, on most monitors, we sort of imagine that we're looking at like a particular lead, like 1, 2, or 3, or something like that. But most of the time, you don't know what leads you're looking at. When I was a fellow at Boston Children's, they used to be very anal compulsive about making the leads a particular lead on the EKG, but that's not usually the case. So this is a long way of saying we don't know what leads these are.
okay.
But the nice thing about this monitor in this particular case is that there are 3 leads.
And they're simultaneous, right?
Yes, they are.
So it's interesting that on channel 3, there are only few kind of deflections or complexes. I wonder if those are the actual QRSs, and then.
That's a very astute observation, Dr. Zabia. So yeah, that's the point of this tracing, which is that, you know, when you see a tracing like this, that's so normal looking, it's very likely that this is artifact. Also, I mean, when you think about it, are you aware of any arrhythmia that looks like this? I mean, it looks scary, right? There's lots of beats of some sort, but this is all artifact. And this is, in fact, sinus bradycardia. And the reason I wanted to show this was just because I think it's important to remember how important it is to have multiple leads when assessing any kind of arrhythmia question. And, oftentimes, or not oftentimes, but occasionally you guys will text me in the middle of the night and show me like this photograph of a single lead from the monitor. And it's kind of difficult to make the assessment because, as you can see, if you had only channel 1 or channel 2, you could be easily mistaken in terms of your analysis. Having 3 channels is a benefit. This is important because, for example, in our practice, we use a lot of ZO patches. Well, the ZO patch only gives us 1 lead. So that is a big disadvantage of this type of monitor. Now, it happens that it generally is a very clear lead, and I have not really encountered this type of artifact on the ZO patches, not with any regularity, but it is something that gives pause. And in fact, this is one of the benefits of a standard old-fashioned Holter, which is that most Holters will usually have a minimum of 2 leads, sometimes 3. And so if you're looking for a very subtle thing, it might be better to use a different kind of monitor than a ZO. Now, the benefits of the ZO, there are a lot of other benefits of the ZO that, in my view, outweigh this, which are things like patient compliance, ability to measure multiple days, things of that nature, because having sort of grown up in the era of Holters, I can tell you that probably 30% of patients who wore a Holter would not even get 24 hours recorded because either stickers would fall off or the patient didn't like it or whatever the case may be. It seemed like the compliance was not great with Holters as a general rule. But with these single patch devices like the ZO or the Barty device, it's been my impression that compliance is markedly better. So we've traded the ability to see this type of analysis for the ability to have any tracings. Okay. All right. So this is a baby with WPW who is on amiodarone. I want to thank one of the fellows for sending me this tracing. Why is the patient not pre-excited, or alternatively, is the patient pre-excited? So I'm going to turn to Dr. Uzoma Obiaka from the state of Alabama for her expert analysis.
Good morning, Dr. Voss.
Good morning, Uzo.
So looking through the tracing, baby seems to be in sinus rhythm. We're talking more about pre-excitation or the lack of it. Patient does not appear to be pre-excited.
I agree with you, Uzo. Why is that important? So probably somebody thinks this patient has a lot of SVT or tachycardia, or else they would not be on amiodarone. So what does the absence of pre-excitation tell you?
It tells me that the amio is probably therapeutic, or at least is having some effect on the rhythm.
Right. It seems to be clearly blocking antegrade conduction for WPW, right? And that's a good indirect sign that there's a lot of effect of drug. The other thing that I didn't mention on this is this patient has Ebstein's anomaly. And this was a point I really wanted to make for you all, which is that when a patient with Ebstein's anomaly has a complete right bundle or a right bundle morphology to their QRS, that is a very good sign that there is not WPW. Okay, so when we, as you know, patients with Ebstein's anomaly have a very high incidence of WPW. I think it could be as high as 50% or even higher. And they also have a high incidence of multiple accessory pathways. When a patient has been ablated for WPW, one of the best signs that the pathway was ablated and that there's no antegrade conduction is the presence of a right bundle morphology in the right precordial leads. That is sort of a clinical pearl. It's important to remember if you have a patient with WPW, and particularly in the setting of Ebstein's anomaly. Most non-pre-excited Ebstein's patients have a right bundle. And so a good proof that you have successfully ablated somebody, or in this case, have blocked antegrade conduction with your drug therapy, is the appearance of a right bundle. So you should keep it's a very good pearl to keep in the back of your mind when you're thinking about or when you're evaluating a patient with Ebstein's anomaly and on WPW. So I just wanted to mention that. Now, it's important also to remember that although you're right, Uzo, that antegrade conduction is blocked, and that certainly would be very reassuring in terms of risk for sudden cardiac death from rapid conduction. And it would probably suggest that the pathway cannot conduct antegrade and presumably also not retrograde. But this patient actually continued to have tachycardia. So why do you think it is, Uzo, that if the patient is not pre-excited any longer on amiodarone, that they can still have SVT?
So if they have multiple pathways,
They can.
then you might have just ablated one and then another pops up. It could also be that they might also coincidentally have both AVNRT and AVRT.
Yep, that's certainly possible. Those are both possible possibilities. It's also possible that you can have antegrade block, but not retrograde block.
Retrograde, yeah.
Right? Patient could still conduct retrograde through the pathway, but not antegrade. And we see that all the time. Well, not all the time, but we see that with some regularity. For example, you can have antegrade heart block, but you could have retrograde conduction through the AV node. This is the reason, as we've discussed many times, why patients can have pacemaker-mediated tachycardia, because they can, when they pace the ventricle, although there is antegrade heart block, there could be VA conduction through the AV node. So it's important to just keep that in mind. But generally speaking, this type of ECG on someone on amiodarone would be a reassuring tracing, which would suggest that the pathway should be well blocked. That the patient continues to have SVT is disappointing, particularly when the phone calls come at 2 in the morning. Okay. This is also from pdcardiology.net. There are a couple of wide QRS beats on this tracing. Are these PVCs or PACs? Let's ask Dr. Grace Kong for her insights.
So looking at the premature beats, I'm trying to look for a P wave beat for each of them. And I am convinced that I see a PB for each of the premature beats. So it makes me think that this is a PAC with and without aberrancy.
Yeah, I agree. That's right. So you want to look to see if you can see a P wave. And I agree with you that there is a suggestion of a P wave that's on the end of the T wave and this beat similarly here. So these are PACs, which are intermittently aberrantly conducting. Very good. Let me ask Sergey, what kind of pacemaker does this patient have?
What kind of pacemaker? 1 second.
I'm not asking the model or I'm not asking the
Yeah, of course. The only one I know is Medtronic.
No, but that's a problem. It means we're not putting in enough variant devices. I'll have to remind Josie the next one has to be a different brand, maybe Boston Scientific.
So what I'm seeing here is trying to see if I see P waves or no P waves. And I think I do see P waves after T waves, and then so it's probably a dual chamber pacemaker that senses the atriums and paces the ventricles.
Well, I think you're basing that statement on these two beats, I'm assuming. Is that right? Because you're seeing
Yeah.
the wave before the.
Mhm.
Is the PR interval? What do you think about this PR interval?
Oh yeah, the PR is long, so the dual
It's
chamber
likely
would.
that the patient would be programmed in such a manner to have
Mm.
a PR of like 400 milliseconds.
So then I changed my answer to a single chamber pacemaker that's only pacing the ventricles.
Right. So this is the point is that when you're trying to figure this out, you have to look at a bunch of beats, right? If you look at these beats here, there isn't an obvious P wave before, right? I agree, there is a P wave here before each of them, but first of all, the PR is very long, so it seems unlikely that somebody would have programmed a dual chamber pacemaker with such a long PR interval. The other important fact is that the PR interval's changing, right? If you're assuming that this is A sense V paced rhythm, why would there be a PR interval of 350 on the first beat and 450 on the next? So, and then when you look along the end, you don't, if you look carefully on the rhythm strip at the bottom, you can see that there's a P wave sort of, it's sort of moving all over the place on the T wave. And there's really a complete dissociation between the atrium and the ventricle. So this is a ventricular pacemaker, a single chamber device. And this is a VVI programmed device. All right. So Uzo, you got a halter on somebody, and this is on a patient who has WPW. And this is the tracing that you have. So can you can you surmise anything about the patient's WPW from this tracing?
So the patient is intermittently pre-excited, not consistently pre-excited.
Mm-hmm.
So it's likely this patient is not going to conduct at rapid heart rates. So lower risk, likely lower risk.
That's exactly right. That's very good. So this, generally speaking, sudden abrupt loss of pre-excitation on a resting ECG or on a monitor would be considered evidence for low risk for sudden cardiac death. Now, there are exceptions to this rule, and there are a number of case reports, studies of rare patients who have had this finding and who during formal testing did have a high risk pathway. But as a general rule, if you are intermittently pre-excited or intermittently manifest in your WPW, we would consider that to be one of the lower risk categories of WPW. And in fact, the official statement from the American College of Cardiology, AHA, and Heart Rhythm Society, written by Mitch Cohn like 10 years ago, says that if you find this on some type of a monitor, you can, in the absence of symptoms in an asymptomatic WPW patient, you can clear them for sports, and you do not need to do any further formal electrophysiologic testing. Now, there are a lot of people who don't agree with that because of the rare cases that have been reported of people who have had findings like this and have then been determined to have high risk or who even died suddenly. But these are extremely rare cases. And so generally speaking, though, if you find this, you would be very reassured or quite reassured about the possibility that this is not a high-risk patient. I've had conversations with Dr. Arnon, who does our stresses, and it's very common when you don't have this on a monitor, the next step would be to do a stress test to see if there is abrupt and sudden loss of pre-excitation, as we're seeing on this tracing. And she has made the observation, as have I, that it is very unusual to see this. And in some regard, she almost feels it's a waste of time to do this type of testing. My general approach is that in a patient who's pre-excited and is not losing pre-excitation, on a monitor, I would almost always do a stress test, because In an asymptomatic WPW patient, you might rarely be able to rule it out as a high risk and avoid an EP study. And although EP study is a very low risk procedure, it is not a zero risk procedure. And so my personal bias is that I would do a stress test because it's a non-invasive study. It carries virtually no risk to the patient at all, and it is certainly lower risk than doing an EP study. That said, there are a lot of people who feel increasingly that all WPW patients should be studied and potentially ablated. Because of these rare cases, I think this is a moving target and will likely change over the next couple of years. But for right now, what you said initially, Uzo, is 100% correct, which is that this would be suggestive of a non-high risk WPW patient for a risk of sudden cardiac death from rapidly conducted atrial fibrillation. And I think with that, we're going to stop today. I appreciate everybody joining. Hope you found this somewhat helpful. And I will see you at a conference in just a few minutes. If I don't see you, have a wonderful day, everybody.
Thank you.
Thank you.